All right, good morning. Thank you all so much for joining us for Grand Rounds today. And I'm excited to first introduce Dr. Chicklees, who's going to introduce our speaker for today.
All right. Good morning, everyone. It is my absolute pleasure to introduce this morning's Grand Round speaker, Dr. Scott Hadland, who will talk to us today about how pediatric providers can address the national overdose crisis. Dr. Hadland is one of only a handful of physicians in the U.S. who are triple board certified in general pediatrics, adolescent medicine, and addiction medicine. He grew up in Canada, attended medical school at WashU, and then went on to pediatrics residency at the Boston Combined Residency Program in pediatrics. That is where our two paths intersected, and he was my senior resident and then chief resident. You may recognize his co-chief in my slide. Our very own beloved Celine Sagalowski with our program director here. Scott stayed in Boston, completing a fellowship in adolescent medicine and then joining the faculty at BU and Boston Medical Center. In 2021, he recently became the chief of the Division of Adolescent and Young Adult Medicine at MassGeneral Hospital for Children. Dr. Hadland is an expert and national leader in adolescent substance use disorder prevention and treatment, and he's been consistent and steadfast in his goal to bring addiction care into the pediatric medical home. He was the 2020 recipient of the Emerging Leader Award in Adolescent Health from the AAP. His work has been published in The Lancet, the BMJ, Pediatrics, JAMA Pediatrics, and he has been featured in media outlets such as the New York Times, Washington Post, NBC News, and NPR. Dr. Hadland has accomplished so much at such a young age, but what I wanted to highlight is that he is just an incredible person. He's a phenomenal teacher, a trustworthy colleague, a strong but quiet leader, and he's a genuinely caring physician. I recently asked him what he was most proud of, and he told me that of all of his accomplishments, he's the most proud of the clinical care his team gives in helping his patients go into long-term recovery and go on to live happy, healthy, and safe lives. I was wondering how Scott got to be where he is and what his adolescence was like, so I did what any normal person would do. I asked his parents. They told me that he was involved in a bunch of different clubs and activities as a teen, including student council and his favorite, drama. The drama background makes sense since he is so well-spoken, confident, and charismatic. They said that he always put family first and that he sets goals and works really hard to achieve them, but he also plays hard and likes to relax when he can. And of course, they sent me a few teenager, adolescent pictures of Scott. So here's teenage Scott relaxing on the beach in Thailand, if you notice his Abercrombie & Fitch 1990s shirt. And then I couldn't miss the opportunity to highlight his perfect 1990s frosted tip. The first time I heard Scott speak was 10 years ago when I was an intern, and he presented his research on childhood sexual abuse and risk for initiating IV drug use during adolescence and young adulthood. I distinctly remembered being inspired and reinvigorated, and I hope today that you are too. With that, I'd like to welcome Dr. Scott Hadland to give Grand Rounds today.
Wow. Thank you so much, Erin. Thank you for that wonderful introduction. Boy, you really did your research there. And I'm glad you gave my parents something to do, because my sense from afar is all they do is sit around, read books, and golf all day. So I'm glad you pulled them out of their sleepy retirement to do something useful. It's so wonderful to be here and to be reunited with lots of folks, others who Erin didn't mention, but are also folks that we trained with that have joined you all at NYU. And it's really an honor to be here among you all and talk about this subject that's so important to me. Let me just pull up my slides here. All right, and maybe if I could just get a thumbs up from Britt or from Erin if everything looks good. All right. So as I said, it's an honor to talk to you today a little bit about our clinical and research work that we do at our program here at MGH. And I'm going to talk to you today about how pediatric providers like you all can address the national overdose crisis. And I'm going to talk about this from my perspective as a clinician, as an investigator, as an educator, and draw a lot on our work in our clinic taking care of adolescents and young adults, really between the age ranges of about 13 and 29. We've got a pretty loose definition of what we call adolescent. and some of the struggles that they've had with substance use disorders. And we care for young people who have struggled with substances ranging from, vaping and nicotine and alcohol and cannabis, really all the way out to youth who inject heroin or inject cocaine or methamphetamine and are at risk for HIV and hepatitis C. So we really are sort of providing care across the full gamut of substance use disorders, both in the substance that's used and then in the intensity of that use. And I have no conflicts of interest to disclose this morning. So my goals for today are, first of all, to convince you that children and adolescents have not been spared from the rise in morbidity and mortality attributable to opioids that we hear about all the time on the news. And by the end of today's talk, the goals will be to describe the epidemiology of substance use-related harm in the US with a focus on adolescents and young adults, which you'll hear me just call youth throughout the presentation. Prescribe opioids in a manner that reduces the likelihood of risk for long-term opioid use and addiction, and ensure evidence-based screening and treatment for youth with opioid use disorders. And I don't know if Celine Sagalowski is joining us today, but we had a never-ending debate as chief residents as to whether or not at the end of a bullet point on a slide, you should put punctuation. And Celine was strongly in favor of punctuation, and I'm happy to report today that I now am too. So part one, we'll talk about the epidemiology. As I said, we hear about this all the time in the news. Drug overdose deaths have skyrocketed, and we're actually at a point where probably any day now we will surpass 1 million drug overdose deaths since the turn of the century. And this is now surpassing the number of people that are dying from a lot of other causes that we know of and think of commonly, like motor vehicle crashes or even cancer. And what you can see is that the deaths are not slowing down, they're accelerating. And we actually were lulled into a little bit of a sense of reassurance sort of in 2017, 2018, and 2019, when we saw that drug overdose deaths had started to plateau a little bit. And then, of course, came COVID. And with COVID came social isolation, came limitations in people's access to treatment, particularly in-person treatment from substance use disorder programs. Limitations on people's ability to gather when they're part of a recovery community. And you can see that in 2020, drug overdose deaths just shot up to really a truly unprecedented number. And we're now at the point where more than 100,000 people die each year from drug overdoses in the United States. So key questions that I think we should all ask as pediatricians are, first of all, what's happening with youth overdose rates? I just presented the data for all people, including adults. And then which opioids are involved? What percentage of youth use opioids non-medically? When does opioid use rise to the level of a formal diagnosis of what we call addiction? And then what are some of the neurobiological underpinnings of addiction? And I think this last bullet point is really important because we have new and evolving understandings of what addiction is doing in the brain. So here's what's going on with drug overdose deaths among young people. First of all, it's worth highlighting that what has gone on in adults with the type of opioid involved in drug overdoses is also going on in teens. So between 1999 and 2016, the last time there was sort of a good comprehensive report on this, overdose deaths rose among 15 to 19-year-olds by 95% for prescription opioids. They rose by 405% for heroin, and then they rose by nearly 3,000% for fentanyl. And really, fentanyl contamination is now implicated in a majority of overdose deaths across the entire United States for everybody and also for youth. Fentanyl is highly potent. There are different estimates on its potency. Some people say it's about 25 times more potent than heroin. I think the true number is probably that it's about 50 to 100 times more potent than heroin, meaning that when you use fentanyl, it takes only very small amounts of it to cause a fatal overdose. And to be very clear, this is fentanyl that is not prescribed by prescribers. This is actually typically illicitly manufactured overseas and then brought into the United States, typically most commonly from China and or Mexico, and increasingly being produced here in the United States and then incorporated into the drug supply. And it's so ubiquitous now that even when a young person thinks that they're buying on the street, an oxycodone 5 milligram tablet, what they're probably buying is a counterfeit pill that has been made with fentanyl mixed with an inert substance and then pressed to look like a legitimate pill using a home pill press that can create something that looks and otherwise seems exactly like oxycodone, but has a variable amount of fentanyl in it and can be very dangerous because of it. I want to highlight here this figure here in the top right. This is the result of a report from one of my mentees, Dr. Jamie Lim. And what Jamie found is that, yes, drug overdose deaths in youth aged 13 to 25 is what he studied here, across the US increased significantly and consistently across the last 2 decades. But what's really interesting is that Jamie found that beginning in 2017, you can see that these 2 lines cross. These 2 lines represent youth who died in an overdose that involved only an opioid versus youth who died in an overdose involving opioids plus another substance. And that plus another substance line, which is the orange line here, has now become more frequent, meaning that it is more common for youth to die from polysubstance use rather than die from opioids alone. And if you ask the question, what substances are involved in these polysubstance use overdose deaths, what Jamie found is that most commonly it's cocaine. The second most common other substance involved is a benzodiazepine. And then the third most common substance involved is methamphetamine. If that hasn't convinced you that we should be worried about youth in this crisis, here are some other data points. First of all, if you ask all adults in treatment for opioid use disorder, 2 out of 3 of them will tell you that the very first time that they used an opioid was before the age of 25. And 1 out of 3 will report that the first time they used was before the age of 18. And so this highlights, this is really a pediatric onset condition. Youth are starting to use opioids during precisely the ages in which they're under our care as pediatricians. And then, to give you a sense of the prevalence of opioid misuse among young people, you can turn to, and I have included here, data from Monitoring the Future. And what this figure reports is ranging on the left from 2000 all the way up to 2020 here on the right, the percentage of youth who in their high school senior year report having used narcotics other than heroin ever in their lifetime. And that's really sort of prescription pills. Anybody that's ever used sort of like oxycodone or hydrocodone and used it not because they had a doctor's prescription, but used it for sort of recreational or non-medical purposes. There are some good news. This trend line has gone down after reaching a peak kind of in the late 2000s. It's now declined nicely with each subsequent year. But you can see that in the year 2020, the most recent year for which we have data, it still represents about 1 in 19 students, meaning that about 1 to 2 students in a typical high school classroom have misused prescription opioids. And if you multiply that out across the country, you can see that we have a real public health problem. The prevalence of this is starting to approach the prevalence of common pediatric conditions that we think of all the time, like asthma, for example, or allergies. So what do we mean when I talk about addiction? I said I would sort of say what the definition is. Well, we now use a definition that was laid out in the DSM-5 for opioid use disorder. So we've scrapped the old terms. You might remember the old terms, opioid abuse and opioid dependence. At the end of this talk, I'll talk about why we try to avoid using those terms altogether and now just use this unified diagnosis of opioid use disorder. And it's really opioid use with at least 2 of the following criteria. And I'm not going to go through all of these criteria. I'm going to try to clump them for you. So the first clump I want to draw your attention to is numbers 10 and 11. These represent physiologic changes in the body that take place from repeated exposure to opioids. And so this includes tolerance, the idea that it takes more and more for you to get the same high from use of opioids, or put differently, if you use the same amount of opioids that you used to, you won't get the same effect that you used to. And then withdrawal is the characteristic set of symptoms that somebody gets when they've been using opioids for a while and then stop. And those symptoms typically include wide pupils. They include things like diarrhea, pain in the joints, tachycardia, high blood pressure, feelings of anxiety, goosebumps, the constellation of symptoms that we tend to think of as sort of cold turkey when somebody's coming off opioids. So that's the first clump, the physiologic changes that take place in the body. Then the remainder of the criteria kind of fall into two major camps. The first camp, which is kind of represented here at the top, is loss of control over your use of opioids. And then the second camp is problems in your life resulting from opioids. And so this is the definition of opioid use disorder: physiologic changes, loss of control over your use, and persistent use despite the problems that opioids cause. And I think this last point is a really important one to think about, because I think sometimes when patients are admitted to the hospital and they're misusing substances, opioids or otherwise, we kind of tend to think like, why can't you just stop? Or why are you behaving so irrationally? And the truth is that that's actually the very definition of a substance use disorder: to have irrational behavior, to continue to want to use substances despite the clear problems that they cause. And that's all grounded in our definition of opioid use disorder. And why do you see these abnormal behavior changes? Well, it all comes down to brain biology. And we actually increasingly, in the same way that we think of arrhythmias as a heart condition, and asthma as a lung condition, I think we can all think of addiction as a brain condition. So let me talk you through what our current understanding is of the neurobiology of addiction, because I think this is important and lays the groundwork for understanding why our patients with addiction sort of, behave the way that they do. And this has evolved a lot in recent years. When I was in medical school, I really only learned about kind of these first two parts of the cycle of addiction. The cycle of addiction has three parts that are, in this figure, blue, red, and green. So the blue part is the part that we're all very familiar with. This is mediated by parts of the brain like the nucleus accumbens and the ventral tegmental area, these sort of parts of the brain that are responsible for dopamine release and rewards. And so when you use substances, you become intoxicated and you get that euphoria, at least initially, and you feel good from using them. The second part of the cycle of addiction is this part here in red, and this is withdrawal and negative affect from use of substances over and over. And so the withdrawal symptoms that somebody experiences when they stop using opioids include a lot of sympathetic features. We talked about high blood pressure and tachycardia, increased respiratory rate. These are all related to activity in the locus coeruleus, which is responsible for release of norepinephrine. And so you get this sort of norepinephrine surge, and that mediates a lot of the sympathetic effects of withdrawal from opioids. Another part of the brain that's really active during the withdrawal and negative affect phase is the amygdala. And so when you have a patient who is withdrawing from opioid use disorder in the hospital, you may notice that they seem very fearful, very anxious. Well, that's really mediated by sort of the revving up of these fear centers and emotional centers in the brain, like the amygdala. So those two phases of addiction, I think many of us are sort of a little bit more familiar with. But this third phase, or third part of the cycle of addiction, which is preoccupation and anticipation, is not always well understood by people and is sort of a more recent understanding that the field has come to. And this is really mediated by parts of the brain, like the secondary association centers in the orbitofrontal cortex and other cortical areas that are really responsible for planning and behavior. And what happens is, as somebody uses opioids or any other substances repeatedly over time, these parts of the brain become really preoccupied with the next time that somebody's going to use. And these circuits sort of progress to a point where they become sort of even more sort of neuroadapted and more strongly oriented towards the next times that you're going to use, such that when somebody is not using opioids, they constantly are experiencing cravings. If they go back to old parts of their world, like, down a street where they used to use, or they're surrounded by people that they used to use with, or they experience the same stressors that used to cue them to use, they'll experience strong cravings. And these parts of the brain become very powerfully oriented around the next time somebody's going to use. And so when you see completely irrational or seemingly irrational behavior in somebody with an opioid use disorder, it's because these cortical areas have become so supercharged towards the next time that somebody's going to use. So with that as our context, let's talk about something that's a little bit of a gear shift. And that is how do we prescribe opioids appropriately? And this is something that all of us in all of our pediatric practices across all of our specialties and subspecialties can apply to our own work. And I really want to highlight here that the pendulum has swung. When I was in medical school in the early to mid 2000s, we always talked about pain as the fifth vital signs. You know, we would say things like, we should always treat pain. It's cruel and unusual to not treat pain. You can't get addicted to opioids if you're treating somebody with pain. And then sort of in the late 2000s, early 2000 teens, we started to panic. We realized there was an opioid overdose crisis. It was fueled by prescription opioids. And we started to say, whoa, we need to stop prescribing opioids altogether. And to this day, there are emergency departments that say, hey, we as a matter of policy don't prescribe opioids. And I think that's also not right, because opioids have a place in treating severe acute pain and can be very helpful for many patients who otherwise can't function because of pain. And so I really want us to land in the middle in this pendulum swing where we say, hey, you know, we should still prescribe opioids when they're indicated, but we need to be very thoughtful when we do so. So key questions for us as pediatricians are, first of all, what do recent trends in pediatric opioid prescribing rates show? Two, what is the risk that after an initial prescription for an opioid, you as a prescriber will have contributed to an adolescent or young adult experiencing an overdose or developing addiction? Three, which youth are at risk of developing these problems? And then four, what are some steps that we should all take before prescribing an opioid? Or before prescribing an opioid in the first place, what are some things that we should do? And then when we are actually prescribing that opioids, how do we sort of minimize the risk associated with that opioid? So let's start with that first question. What's going on with opioid dispensing rates? Dr. Maddie Rennie, one of your colleagues in the emergency department, recently published this piece, which does a really nice job of highlighting the extent to which we've actually really cut back on our opioid prescribing. So in this figure, so she looked at data from across retail pharmacies across the United States in a comprehensive database, and found that if you look from 2006 to 2018, the most recent year for which she had data, and you look at the rate of opioid prescriptions, they have really declined. You can see that the rate of opioid prescriptions per 100 persons in the 2020 to 24 age range, which is this orange line, you know, we were at a point where you know, more than 1 in 3 people in this age range had been prescribed opioids. So these were exceptionally common for people to have received. And they were also exceptionally common in this 15 to 19-year-old age range, in which that number really approached about 1 in 5. Rates of opioid prescription in younger kids were much, much lower. But then you can see that we've really cut back such that in the year 2018, there's been this really sort of steady decline in the rate of prescription. So we've cut back overall. What I think the question that we need to think through is this overall cutback good? Is it bad? I would argue that it's a bit of both, right? This inevitably includes people who are getting inappropriate opioid prescriptions and shouldn't have gotten them in the first place, but it probably also includes people who would have benefited from an opioid and may have had uncontrolled pain and didn't get an opioid. Our group and another group led by Dr. Chua at University of Michigan have done a couple of studies to identify, you know, what is the risk of developing a problem from an opioid prescription, and then who's at risk. So what Dr. Chua's group and our group did was we both examined youth with commercial health insurance across the United States. Their group studied 12 to 21-year-olds between 2009 and 2017. And our group studied a slightly older group between 11 and 25 between 2006 and 2016. And Dr. Chua's group asked the question, when young people are prescribed an opioid, how common is it for them to have an overdose while on that prescription? And the answer is, it's exceptionally rare. Only 1 in 11,000 youth had an overdose while on a prescription for an opioid. So that's a really low prevalence. our group asked a slightly different question. We said, well, maybe it's not that you're going to have a problem with an opioid while you're on the prescription. Maybe it's going to happen in the year after you get that prescription. Maybe you get exposed to an opioid, and then that sort of starts you on a pathway towards a problem with opioids that sort of continues and turns into maybe difficulties with heroin or fentanyl or other substances. And so we looked a year out, and then we also looked at not just rates of overdose, but also rates of opioid use disorder, actually developing a problem with addiction. And what we found is the number was higher, but it's actually still quite low, that fewer than 1 in 300 youth had a problem with an opioid after it was prescribed. So what that tells me and should tell you as prescribers is that on an individual patient level, if you're working in the emergency department and you see a patient who has a dental abscess and you decide, hey, I'm going to prescribe an opioid because this patient is in severe pain and ibuprofen and acetaminophen are not cutting it, fewer than 1 in 300 youth are going to have a problem with that opioid. In fact, 299 out of every 300 youth are going to be just fine. So that should be really reassuring. But on a public health level, that starts to become a problem because, again, if you multiply this out by all the youth across the United States in every emergency department, we start to have a bit of a crisis. And so what Dr. Chua's group and what our group did is then ask the next question of, well, who's actually at risk? And what we found are that there are some risks associated with the prescription itself, independent of what's going on with the patient. And risks that set you up for a potential problem with addiction or overdose include prescribing a long-acting opioid formulation like MS-Contin or OxyContin, prescribing high daily doses of opioids, and then prescribing opioids for durations longer than 7 days. On the other hand, and probably more important than those prescription risk factors are some individual patient level risk factors. So some of these risk factors that we identified include male sex, chronic pain conditions, mood and anxiety disorders, psychosis, ADHD, trauma and stress related conditions. But this last point here, and I can't emphasize this enough, and that's why I put 3 asterisks here, is that the single biggest risk factor identified across studies, including ours and Dr. Chua's, is that patients who are at risk for having a problem with addiction are those that already misuse other substances. So when you prescribe an opioid, youth are going to be at risk for developing addiction if they're already misusing other substances. And I want to be really clear that those substances don't have to be other prescription pills. They're actually most commonly cannabis, alcohol, and or nicotine. In fact, nicotine is the most common. And so what that tells me is that it's really critically important for us before prescribing an opioid to try to understand if somebody has a problem with other substances. And so I'm going to spend a big part of this presentation at the end explaining how we can all screen for substance use in youth, just as a matter of our regular routine practice, and as part of our assessment for somebody who we might be prescribing an opioid to. So, what are some best practices before prescribing an opioid? Well, the first thing we want to do before prescribing an opioid, and I think we all do this really well as pediatricians, is to maximize our non-pharmacologic options. So we want to make sure that our patients are getting physical therapy, that they're using relaxation techniques, and then we also want to max out our non-opioid pharmacologic options like NSAIDs, like ibuprofen or naproxen, or other medications like acetaminophen. Then if we're going to prescribe an opioid, we want to conduct an assessment of risk factors. So as I said before, one of the most critical pieces of information is to know whether they have another substance use disorder. Are they also struggling with nicotine, cannabis, or alcohol, which are the most common substances that youth struggle with? Do they have other mental health problems like mood or anxiety disorders? Do they have a family history of addiction? And again, I don't want you to think that it's only sort of people who have parents with opioid addiction become the kids with opioid addiction. There's actually a lot of sort of crosstalk across substances, meaning that if you look back, when I ask my patients with opioid addiction, do you have a family history of addiction? The most common thing I hear is, yeah, I have a parent who struggled with alcohol use disorder. That link between alcohol use disorder and opioid use disorder in offspring is actually a very strong one. So you want to ask about all types of addiction, not just opioid addiction. And then the last best practice is to check your state prescription drug monitoring program, of which there's a good one in New York State. And in fact, there are good ones in every state except for Missouri, which has, at least at my last check, not yet adopted one. But otherwise, all other states have them. And then when you are prescribing an opioid, here are some best practices. First of all, you want to use the lowest effective dose of a short-acting formulation. Here, something like hydrocodone or oxycodone is probably a very good option. And don't use long-acting opioids for acute pain. Long-acting opioids can be used in chronic pain conditions, but because of their association with risk for addiction and overdose, we should not be using MS-Contin or OxyContin or other similar formulations when we're treating acute pain. We want to avoid co-prescribing of other sedatives, so patients on benzodiazepines, or even patients who drink alcohol or maybe using anti-epileptic drugs. We just want to be thoughtful about whether these might have a synergistic sedative effect. Doesn't mean we can't prescribe opioids in these settings, but we just want to be very careful and mindful when we do. We want to offer a short course of opioids, meaning typically 3 or fewer days. That's often enough in acute pain situations, and patients and families can always, contact us if they need more. And then we want to notify parents of minors, review safe storage with them, talk to them about how to lock medications up. We want to advise parents that, hey, it's probably best for you to directly administer the medication to your child rather than having them hang on to the bottle. And that way you can keep an eye on the pills and make sure that they're not being misused. Just sort of talking through parents how to safely manage this stuff. And then a slight tangent here, but I think a really important one for us as pediatricians is that I think this is largely floated under the radar, but in 2017, the FDA came out with a series of warnings and contraindications around the use of certain opioids that I think many of us in pediatrics, I certainly didn't notice when this first came out. And the American Academy of Pediatrics totally agrees with these recommendations and has tried to get this information out to pediatricians, but it still hasn't quite permeated our clinical practices yet. And that's these warnings and contraindications around the use of codeine and tramadol. And I'll talk through what these contraindications and warnings are, but I just want to say it's probably best not to use codeine and tramadol at all in people under the age of 18. So here are the contraindications and warnings. For children under the age of 12, we should not ever use codeine or tramadol. And the FDA says that we shouldn't because they're metabolized differently by different kids. And they are a setup for risk of serious breathing problems and death in this age group. So we sometimes think, hey, codeine and tramadol, they're sort of less potent opioids. Let's use them instead of the sort of full agonist opioids like oxycodone or hydrocodone. But actually, because of these differences in how they're metabolized, they actually probably cause much, much more harm than the other opioids. In adolescents age 12 to 18, there's a contraindication for the use of tramadol for postoperative pain after removal of tonsils and adenoids. And there's a warning against the use of codeine and tramadol for pain management in patients with obesity, obstructive sleep apnea, or severe lung disease. And basically, this collection of sort of warnings all centers on the idea that if you have a patient who has any sort of baseline airway compromise because they've recently had surgery, or they may have sort of excessive tissue in the neck area, or they may have severe lung disease, that these medications could be metabolized differently in certain individuals and place them at risk for breathing problems and death. So I just honestly never use codeine and tramadol in people under the age of 18. What do I use instead? I use hydrocodone or oxycodone. So with that as sort of our baseline for best practices in opioid prescribing, I'm now going to pivot back to talking about youth at risk or who have at risk for or who have addiction, and talk about how do we screen and treat for opioid addiction and really addiction just writ large. And I want to highlight that our group and other groups have sort of pieced together a cascade of care to try to understand, what kind of treatment do youth with addiction to opioids get, and where are we falling short? And the answer is we, as a sort of youth-oriented workforce, are doing abysmally when it comes to treating opioid use disorder. If you take all youth between the ages of 12 and 25 and ask what percentage have opioid use disorder, the answer is that the true prevalence of opioid use disorder is about a little over 1 in 100. And it varies from state to state. Here in Massachusetts, it's actually closer to about 1 in 20. I'm sorry, that's an overstatement. It's actually about 1 in 50 here in Massachusetts. But the bottom line is, across the country, about 1 in 100 youth have opioid use disorder. But only 0.3% of all youth, 0.3% of all youth actually get identified and diagnosed in a healthcare setting as having opioid use disorder. Once they are identified as having a problem, we do a really bad job of making sure that they get treatment. So the percentage here of the bar that's green is the percentage of this prior stage that actually get any kind of treatment. And the orange is the treatment gap, the percentage of youth that get any treatment whatsoever. How many youth actually start medications for opioid use disorder, which is the standard of care for treating opioid use disorder? An even smaller percentage. What percentage go on to actually engage in treatment and show up in the short term for a repeated series of visits? An even smaller percentage. And then what percentage of treatment of youth stay in treatment in the long term, which is really critical for a chronic relapsing condition like opioid use disorder? Just a slim number. And so the number of youth that get into long-term recovery with our support as clinicians is this just like vanishingly small percentage of all of the youth that actually have a problem. We're doing even worse among youth of color. And so our work and the work of others have shown that Black and Hispanic youth are respectively 65% and 74% less likely to receive any treatment for opioid use disorder. And then they're 32 and 58% respectively less likely to be retained in treatment in the short term. So we do a really really bad job of initiating and engaging youth of color in treatment. And so we have enormous health disparities that we have to grapple with as a field. So key questions that we might ask ourselves as pediatricians are, what constitutes evidence-based treatment for youth with opioid use disorder? How should pediatric providers screen for substance use? Where can providers refer youth with problematic opioid use? And then what are some additional simple things that every one of us should do to take on our role in addressing this opioid overdose crisis in the US? So what does treatment look like? Well, broadly speaking, it has two parts to it. The first part is medication, and the second part is behavioral therapy. There are 3 FDA-approved medications for opioid use disorder, which I'll talk about in a second: buprenorphine, naltrexone, and methadone. And I want to be clear that they're recommended by the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, in a statement that I helped write, and the American Society of Addiction Medicine, because randomized clinical trials show that their use is associated with fewer relapses, fewer cravings for opioids, and longer retention in care. On the behavioral side, this behavioral component to treatment, in my personal experience and in these clinical practice guidelines, is really critical because youth tend to not just present to you with addiction, but also present with comorbid depression, anxiety, ADHD, and other problems that really require intense intervention. There's a bunch of different modalities. We actually haven't figured out which one works best in psychological support because the studies haven't been done yet. So let's talk a little bit about these 3 medications because they are FDA approved, they're recommended, and we use them all the time in our clinical practice with really good results. Starting with methadone. Methadone is a full opioid agonist, meaning it binds to the receptor and has a full effect. But its availability for adolescents under age 18 is extremely limited because of federal guidelines. It can only be administered as a daily oral dose that's administered in person at a qualified methadone center. And most of these programs just won't take adolescents into their programs. Buprenorphine is the medication we most commonly use. It's a partial opioid agonist. It's FDA approved for 16 and up. It's actually the only medication that's FDA approved for adolescents, although we often use medications off-label for younger ages. It's a daily dose of a medication administered as a film or a tablet that's placed under the tongue. It's now available as a monthly dose, as an injection that's given every month, sort of the way that kind of similar to what we do with Depo-Provera or medroxyprogesterone as a depot formulation for birth control, although we give that every 3 months. And it's also available as a semi-annual dose as an implant that can be placed under the arm. This can be provided, or these buprenorphine formulations can be provided by a primary care clinician or really anybody in pediatrics after obtaining a DEA waiver. It used to be you had to do this 8-hour training. That is no longer the case. You now just need to register your DEA number with the federal government, and then you can start prescribing right away. And I would encourage as many of you as possible to get this training or to get this waiver. And our group and other groups can help provide some basic training on how to actually prescribe the medication. And then the third FDA-approved medication is Naltrexone. It's an opioid antagonist. It's FDA approved for 18 and up. It's available as a daily dose and as a monthly dose that goes by the name Vivitrol. And it can be prescribed by any one of us without any special training required. I want to talk to you briefly about the rationale for these 3 medications because they all have different mechanisms of action. And I want to talk to you about why it is that they work. What happens when somebody is out on the street misusing heroin and pills is that they get a sudden spike in their blood levels of opioid, and they get a sudden spike in the physiologic and euphoric effects that they experience. But then they come right down because these are short-acting opioids. So you have to use again, and then again, and then again. And it turns out that over time, it actually becomes harder to attain that high because of tolerance. And you start to develop withdrawal and cravings when you're not using. And so people who use heavily for repeated periods of time really experience this sort of vacillation between experiencing the high of opioids and the terrible withdrawal and cravings of opioids with very little time in between where they feel kind of quote unquote normal. So the goal of buprenorphine and methadone as opioid agonists, one partial, one full, is to wait until somebody comes down off of opioids that they've been using off the street, and then to use these medications, which are much sort of more carefully dosed. You can get them into a nice therapeutic range, and then they're dosed only every 24 hours. And so you can get someone to this normal range where they're not feeling the high, they're not feeling the withdrawal and the cravings, and they're just feeling normal again. And you get them sort of in this safe range, and then they can engage in behavioral therapy and then all the other things that they need to do to live a happy, healthy, normal life. Naltrexone is very different. Naltrexone is an opioid antagonist, and what it's doing is acting mostly in the brain to block the opioid receptor from being able to experience the euphoria or the high from heroin, fentanyl and other opioids. It basically makes it so that you can't experience that reinforcing euphoric effect from using opioids. But it actually has this second mechanism that's really interesting, and that is that it also can reduce cravings in many patients because what it does is that, well, it turns out the pathways in the brain that mediate cravings for all kinds of things, alcohol, eating, gambling, cutting in teens who engage in self-cutting behaviors, all of these different sort of impulsive, compulsive behaviors that are sort of associated with cravings to do them over and over again can be blocked because these pathways are actually mediated by endorphins. And so the body's own endogenous opioids mediate these pathways. And if you block them with naltrexone, you can actually block those cravings. And so that's how naltrexone is actually used for example, alcohol use disorder, binge eating disorder, and some of these other conditions. With all of these different, with this as the backdrop that, we really should be treating youth with opioid use disorder, how good are we doing as a pediatric sort of specialty? We're doing pretty poor. This is actually a paper by one of our mentees and actually somebody that Aaron and others would have worked with during training, Emily Allen. And what she did was did a survey of all pediatric residency programs across the United States, had a nice response rate of 60%, and found that our training in pediatric opioid use disorder is really poor. It's a little bit better in counties in the country when we have residency programs that are located in counties that have been hard hit by opioid overdose, but it's overall not great. So you can see just sort of these diminishing levels of training that we provide in any substance use disorder training, in screening for substance use disorders, in how to treat overdose, in use of medications like buprenorphine, naltrexone, and methadone to treat addiction, in use of naloxone as an opioid reversal overdose agent, which I'll talk about in a second, and then in providing the buprenorphine waiver training that used to be required in order to prescribe the medication. So we have a lot of training to do, and that's part of why I'm here today, is to help set the stage for this for you and give some basic tips. So what are some basic tips for all pediatric providers? Well, the first one is that we really need to screen for substance use and refer for treatment. The second one is actually an easy and even easier one, but one that sometimes people find controversial, and I really want to encourage you to understand that it's not. And that is to discuss harm reduction and overdose prevention with our patient. And then third of all, what we need to do as a society is really change the language that we use to talk about people with addiction to reduce the stigma that they experience everywhere, and then especially in our healthcare settings. So how do you screen for substance use disorders? There's a few different screeners that are available. They're all available online. I'm going to talk to you today about the CRAFFT, which is probably the most commonly used screening tool. It's the one we also use here at MassGeneral. And basically has two parts, Part A and Part B. And in Part A, you ask the question, during the past 12 months, on how many days did you drink alcohol, use cannabis, use anything else to get high, or vape any flavoring or nicotine? So you're really just trying to understand alcohol, cannabis, nicotine, and anything else. And you word it this way in the past 12 months to try to get at use during the last year. So you only care about sort of active and recent use. And then you ask this question on how many days did you? So you don't ask, hey, have you ever done this? You say, you sort of presuppose that they've used, and you say, on how many days did you do it? And because it becomes harder to sort of say like 0 days, this question actually has a higher sensitivity than asking, have you ever done this? And it turns out that the frequency with which somebody uses substances is strongly correlated with their risk of having a true substance use disorder. So a young person who says, hey, you know, I haven't used at all this year, or have only used once or twice in the past year, is very likely to have no substance use disorder whatsoever. Somebody who's using monthly is likely to have a mild to moderate substance use disorder. And then somebody who's using weekly, and we encounter these youth all the time, right? The patient who says, oh, you know, I smoke every day, or I, you know, smoke cannabis on the weekends with my friends every weekend, but I don't have a problem. Those youth actually are very likely to have a severe substance use disorder if you dive in and ask sort of questions about the problems that they're having with substances. And here are just some negative predictive values and sensitivity and specificity parameters around these different findings. The bottom line is like, these are good questions. Part B of the CRAFFT moves on and asks a series of questions that go CRAFFT. And you want to ask the first question, the CAR question, of all youth, because even if a youth isn't using substances, it's possible for them to ride in a car with somebody who is, like a friend or a family member. So you want to ask, have you ever ridden in a car driven by someone, including yourself, who is high or had been using drugs? And if the answer is yes, this is a big safety concern and you want to intervene and make sure that they have safe rides. If they aren't using any substances, you stop there. If they are using any substances, you then want to proceed and ask the rest of these questions because they correlate with the risk of having a substance use disorder again. So you want to ask, do you ever use alcohol or drugs to relax? Do you ever use alone? Do you ever forget things you did while using substances? Do your family or friends ever tell you should cut back? And then have you ever gotten into trouble while you're using alcohol or drugs? And it turns out that the more of these things that a young person answers yes to, the more likely they are to have, again, a substance use disorder, such that the CRAFFT scoring system uses a cutoff of 2, meaning that if you answer yes to 2 of those 6 CRAFFT questions, you now are more likely than not to have a substance use disorder associated with your use of substances. So what do you do when you've identified somebody with a problem? Well, first of all, you should just get to know some of the treatment programs in your area so that you can refer youth. But if you don't know them, you can log into a government-run website. It's just findtreatment.samhsa.gov. You can just Google U.S. government find treatment, and they maintain this Google Maps-based engine where you can type in the patient's address or your own clinical address, give a radius, and then let them know different parameters that you're looking for. And there's a whole drop-down menu here, including being able to check off boxes like, serves adolescents, offers medications, accepts Medicaid, these sorts of common parameters that you want to check for. And then it will bring up a series of programs in your area. Unfortunately, as you get out to more rural areas, like in your area in upstate New York, these programs do become a little bit further and farther in between. So that's what you want to do with all patients. It's a little bit of work, but it's really critically important for us to do as pediatricians. The second bullet can feel a little bit more controversial, but it's not, and is highly effective and easy to do. And that's to provide harm reduction services to our patients. So remember that addiction is a chronic illness. And chronic illnesses like migraines or high blood pressure or diabetes or asthma are going to have some periods that are good and some periods that are bad, right? There's going to be periods of recovery alternating with relapse. And sometimes you're going to have youth come into your emergency department or your clinic, and they're going to be in a period of relapse or use, and they're not going to be ready or able to cut back on their substance use. And even when they're not ready or able in that moment, I think sometimes we as pediatricians sort of say like, well, I can't help you if you're not willing to accept my help. But the truth is, we can do so much other stuff other than getting them to cut back on substances. We can screen and treat for HIV. We can screen and treat for hepatitis C. We can screen and treat for sexually transmitted infections. We can talk to them about how to inject safely, like not sharing your equipment with other people, using clean equipment. We can talk to them about many of the syringe exchange programs that are operating in New York City and other places. We can offer them pre-exposure prophylaxis to reduce their risk of getting HIV. We can offer them education on how to reduce their risk of overdose, telling them, hey, fentanyl's out there, it's highly potent. Before you use something, use just a little bit to see how it makes you feel before going on and using a bit more. Make sure that you don't use alone, use with a friend so that somebody can call 911. It's safe to call 911. The law is set up in a way where if you call 911 and the police show up, you won't be arrested for your substance use. We could talk to people about how to use Naloxone, and I'll talk a little bit more about that in a second. And so you can offer a lot more things than might immediately come to mind that help to make it so that young people engage with you. And when they are ready at a later point in time to reduce their substance use, they know exactly who to turn to because they know exactly who to trust. And I want to be very clear that all of these harm reduction services that we offer are not associated with youth using more drugs or with youth not cutting back on their drug use, meaning this doesn't make problems worse. And these are findings that have come out of major journals that we all know and trust, like JAMA and New England Journal of Medicine and Lancet. There are strong data to suggest we can offer harm reduction safely without putting someone at risk for having worsened addiction. Another easy thing for us to do is to educate and offer Naloxone, educate about and offer Naloxone to our patients. This is an overdose reversal agent recommended by both President Trump and President Biden's Surgeon General. So you can see that this is a very uncontroversial intervention. It is an overdose reversal agent, an opioid antagonist. I want to be clear, it's different from Naltrexone, which we were talking about a minute ago, which is a long-term treatment for opioid use disorder. This is a shorter acting nasal spray most commonly that is given out free from health departments. It can be prescribed and is typically covered by all major insurers. And so we should be offering this to all youth with addiction. And honestly, I think it's probably at this point standard of care to be prescribing it anytime you prescribe an opioid medication, because if that opioid prescription gets misused by somebody, or if a toddler accidentally gets into it and has an accidental poisoning, you've got the antidote to that overdose right on hand, right next to the prescription. And so it's a safety thing. The last thing we need to do as a society, as practitioners and as people just living out in the world, is to change the way we talk about addiction to reduce stigma. There's a lot of ugly language out there that we use to talk about people with addiction. And here are some problematic terms, and here are the preferred terms that in an upcoming policy statement from the American Academy of Pediatrics, you'll see that we've really clarified what these preferred terms are and why we should use them. But just to summarize really quickly, a lot of these really ugly words that we hear, we should really be using person-first language in the same way that we don't say, you know, down the hall in room 302 is that 3-year-old diabetic. We say, down the hall is a 3-year-old boy with diabetes. We want to do the same thing with addiction. We want to say that's a person with a substance use disorder. We actually want to avoid using the word abuse. It turns out that abuse across studies is associated with evoking lots of imagery for practitioners. You know, as pediatricians, the word abuse really evokes things for me like childhood sexual abuse, childhood physical abuse, mental abuse, things that are really kind of just really terrible things. And when somebody uses substances, we're talking about something very different. And so we should use the terms substance use or substance misuse when we're talking about people using substances rather than people abusing substances. There's some other terms here that you'll see that we have preferred terminology because they reduce stigma. But for pediatricians, this last one is really important. In the media all the time, we'll hear about babies born with neonatal opioid withdrawal syndrome as being, quote, born addicted. Well, that doesn't make sense. We've talked about the definition of addiction, and it involves complicated behavioral changes that don't make sense when we're talking about babies. And so we should talk about babies as being born substance exposed, because it's enormously stigmatizing for families when we say, hey, your baby was born addicted. So remember, 3 things that you can do here. And with that, I will stop, say thank you, and be happy to answer a couple of questions in my last minute or two.
Great. Thank you so much, Dr. Hadland. I'm just going to share the QR code for the talk. And I did have a couple questions come in the chat. The first was, could you comment on the role of cannabis being legalized in terms of how it's been playing out for the rest of addiction disorders that we're seeing in teenagers?
Yeah, great question. And I think the worry is that people worry that because cannabis is now legal for medicinal use in a lot of places, including New York, it's now legal for recreational use in many places, including New York, that rates of cannabis would rise and then maybe rates of other substance use would rise. That actually hasn't borne out. Most of the carefully done studies have shown that actually cannabis use has not risen in teens. We probably hit a ceiling where cannabis use is just like so common, unfortunately, among teens that legalization hasn't helped or hurt that problem. And in fact, it hasn't worsened the problem of opioid use disorder. In fact, if anything, there's some studies that suggest that places where cannabis is legal may have actually contributed to a decrease in addiction and opioid overdose, maybe because there's some replacement of people's use of opioids with cannabis, which can also be used to treat pain.
Great, thank you. I've allowed everyone to unmute themselves as well if anyone would like to ask a question in the last moment here. But another question that came in the chat was, is there any specific strategies you would use for kids with ADHD or mood disorders in terms of preventing addiction in these groups?
Yeah, great question. When you have somebody in front of you who struggles with a mental health condition, or even if they struggle with a substance use disorder, maybe they're addicted to nicotine or whatever it may be, you can and should still prescribe an opioid if it's indicated, but just do it with really close follow-up. So as an example, I have patients with opioid addiction who are in recovery who then go on and get a serious surgery and need opioids for that surgery to manage the pain. And I'll still prescribe them opioids. I'll just do it with really close communication. I'll often advise, hey, is there someone who can hold the medication for you, do pill counts for you to help keep you out of trouble? I make sure that they have Naloxone on hand. I make sure that our staff are checking in with them frequently. I only give them a little bit of opioid and I say, I'll prescribe you more if you need it. Just give me a call when you do. So just really close follow-up is the key.
Great, thank you. And then I have another question from Dr. Coble on the chat. Thank you for your amazing work with youth with substance use disorders. As an adolescent trained provider, we truly champion harm reduction strategies in our teens, and we agree with the importance of routine screening of SUD in our patients. But one of the challenges I've seen is the heightened screening in patients with conditions who have chronic pain, such as sickle cell disease. Could you comment on the rates of SUD in this population?
Yeah, we actually don't have great prevalence data on the rates of SUDs specific to sort of every condition. We've got some data on sickle cell disease, but I worry about some of the samples in which those data have been drawn. There actually are a lot of data to suggest that just writ large, youth with chronic health conditions are more likely to have substance use disorders than youth without. And that probably is wrapped up in some of the complexities medically, and then also with, sort of the psychological burden of having a chronic health condition. But again, youth with sickle cell disease need opioids for pain. In fact, they need long-acting opioids for pain, and they should be provided because there's an indication there, and it is important that we treat pain in this population. And so there, I think the key is to differentiate somebody who's using opioids and is gaining function in their life as a result of their opioid use. So somebody who is in pain, but you give them long-acting opioids, and suddenly they're able to do more things. They're able to go to school. They're able to, work. They're able to engage with their friends and family because you've helped lift them out of pain, versus somebody who's having more problems resulting from the opioids, meaning that their opioid use is spiraling out of control. They're using more and more. They're spending a lot of time thinking about opioids, craving opioids. They may be, obtaining opioids on the street. That's when you start to detect that somebody's opioid use is causing problems. And that's sort of the clear line. Do opioids make you more or less functional to help figure out if somebody has a problem?
I know we're over time, but we have several more questions. I don't know, Dr. Hadland, if you have a few more minutes to address some of them.
Yeah, I'll stay as long as folks want. And of course, people should drop off to go do their things if they need to.
Thank you so much. So a question from Dr. Chickles. Thank you for an amazing talk. Are babies born exposed to substances at an increased risk of SUD when they become adolescents?
They are, but we don't think that it is because they sort of had this, terrible brain exposure to opioids that somehow altered their biology. We think it's because of the context in which they're raised. Children born into families affected by addiction have some genetic loading that predisposes to addiction, and then some environmental loading that predisposes to addiction. But it's not doom and gloom. I care for a lot of patients, actually, who are children of parents who struggled with opioid addiction, and their parents want their kid to go see a pediatrician who just could keep an eye out for them. And a lot of these kids have never used substances, have watched what their parents have gone through and said, I will never touch a substance because of what I grew up with, and have enormous protective factors. And so there are in fact, the vast majority of kids do just fine. But there is a risk factor there because of the context in which they grew up.
I see Dr. Lazarus has a hand up. I'm not sure if you're still.
Yeah, thank you. I'm still here. Thanks for a wonderful talk. So how do you advise or guide youth whose friends are in treatment? Let's say one of my son's friends is under the withdrawal, and my son will come to me and say, I think he's using again. How do you give guidance to those young people who are trying to figure out what to do for their friends?
Boy, that is really tough. It is. So first of all, I think our own sort of social circles can help people practice harm reduction just to sort of deal with the immediate harm. And so one thing your son might do as a friend of this person is that they might help secure some naloxone. It's often given out free from health departments. It's often given out free in many hospital settings. I bet there's a clinic at NYU on the adult side that's just giving out naloxone. And so get a couple of doses of that, pass it on to your friend. Maybe your friend passes it on to the person who's using, to make sure that that person has some additional safety in place. Talk to them about safety. Talk to them about, hey, if you ever worried that you have overdosed or used too much, you can always call me. sort of creating a culture of safety for that person. And then in terms of getting someone into treatment, that's really tricky. And although I think we all can try to encourage people to get into treatment, it's not always going to be successful. I think probably the strongest levers often come from people's immediate loved ones, and other people that are sort of really close in somebody's life. So if your son is really close with this person, they can try to encourage them to get into treatment, and maybe help them by driving them to appointments, or
Yeah,
offering to talk them through sort of how to call different programs and things like that. But it's tricky. So I think safety comes first, and then you just do what you can, recognizing that
he,
not
he's
every
he's
attempt
in
is going to be
fact in
successful.
treatment. He is in treatment, but and I guess which I didn't understand, but I suppose even on Vivitrol, they have ways of sort of breaking the system or taking on the days where before the Vivitrol wears off or as it's wearing off.
Yeah. No, it's a good point. I will highlight though, I mean, that's a tough and sort of obviously really concerning situation. Someone on Vivitrol is at least getting probably about 3/4 of the month with good protection. And so by being in treatment, it's better than not being in treatment, even for somebody who's using. And so again, I think
Good
it's
point. Yeah,
often it is helpful to think about addiction not as sort of all or nothing, but actually to think
that's
of it
great.
as a
Yeah,
sort of spectrum and gradient of safety. So this is better than nothing, and I think the goal of your son should be to try to push him even more towards non-use,
that's great. Yeah, I like that idea. Thank you so much. Thanks for the talk.
of course.
Dr. Hadland, thank you for taking additional time, and please stop me or give a wave when you need to go. But I have a question here from, I'm not sure who it is actually, but what are your thoughts on syringe exchange programs being concentrated in poor areas or areas with mainly people of color, despite drug use being far more widespread than just these neighborhoods?
Yeah, this is something we think about and struggle with a lot in Boston. I used to live in Boston's South End neighborhood, which is sort of the epicenter of Boston's drug use market, and also the place where a lot of our services were located. It's where we offered treatment. It's where we had harm reduction services. We had a safe consumption site, meaning that you could not a safe consumption site, a medically supervised site where after you've used out on the street, you could then come in and be medically supervised by nurses to make sure your vitals were stable. And these are life-saving interventions. They prevent HIV, they prevent Hep C, they prevent fatal overdose. They're key. So they should be offered. Unfortunately, they often are located in neighborhoods where people are predominantly sort of like comprised of communities of color, and that is I think on the one hand helpful because communities of color have been disproportionately affected by this opioid crisis. On the other hand, it does affect neighborhoods, and even though I was somebody who is a huge proponent of having these services in my neighborhood, I saw as my neighbors struggled with the day-to-day risk of, coming out onto their stoop and seeing that somebody had overdosed on heroin right on their stoop. And they would do the right thing. They would call 911. They would have Naloxone. They would administer it. But that takes a sort of daily toll on people and on neighborhoods. And so this is something we're struggling with. And I don't know the right answer, other than to say, like, we're all in this together. We're all being affected here. These services are critical, and we need to also acknowledge that we've disproportionately affected communities of color and be mindful and thoughtful in our interventions.
Great. I'm going to jump to a final question here, if that's okay. Thank you so much for this wonderful talk from Dr. Laskowski. Do you know of a screening question for adolescents to identify those who are at high risk of witnessing an overdose and would benefit from receiving a naloxone kit?
I haven't seen a question specifically about other people. I think what's really interesting is that at the end of the day, I talked a lot about the special wording of how you ask about substance use. I think if you do nothing else, just asking the question, the best way you can in the context of a thoughtful conversation with a young person with whom you've built up a relationship is probably the most important thing. Don't get me wrong, you should ask the questions the way the screeners are validated. But for something like this, I would just ask. I would just get, work on your rapport with a young person and then ask the question in a thoughtful way, because that hasn't been studied.
Great. Well, thank you so much for speaking to us so eloquently on such an important topic. It's clearly very high interest from everyone, and we really appreciate you taking the extra time to address these questions as well. So thank you again for joining us. And with that, I will let everyone get on with the rest of their day, and have a great day, everyone.
Thanks so much for having me.
Take care. Bye.